for her initial evaluation, and she lacks 28 degrees of extension and has 72 degrees of flexion. It's now time to unveil Maddie's surgically repaired left knee. Maddie presents to our clinic on the first day. You can see that she has her post-operative dressing and compression wrap still in place. Our sports medicine doctors often send their athletes to begin therapy 3 to 4 days from surgery, which is a little different than the typical outpatient setting where doctors will send them 7 to 10 days after surgery, during which time they will have already seen the physician for their post-operative visit and this dressing is normally removed. In this case, once we get all the gauze and padding out of the way, we can see that there are steri strips in place, the wound looks very good, there was very little bleeding, and there are no signs of infection. You'll also see that the knee was labeled yes to indicate to the surgeon that this was the knee that was to be operated on. Typically, the knee will be grossly swollen. There will be discoloration both from bruising from the surgery as well as the yellow of the betadine that's been applied. Once the dressing is removed, I'll take the knee through motion and get a sense of what the end feel is. Once I have this information, we'll get some baseline measurements, and in this case, we want to try to see if there is full extension. As she's only 4 days out from surgery, we anticipate that she's not going to be able to fully extend her knee because of swelling. Once I have the measurement for extension, I'm going to slowly take the knee up into flexion. Of course, you have to adhere to any guidelines or precautions or limitations the physician may have, and you don't want to push too hard as they are still acutely out from surgery and typically have a lot of pain. Once we get this measurement for flexion, I'll normally also do a Lockman's or anterior drawer to check the firmness of the graft and to get an end feel for this as well. The goals for week 1 are to improve quad function, maintain patellar mobility, and get knee motion from 0 to 90. To improve quad function, we'll often use muscle stim, or NMES. As you can see here, we have 2 leads, one electrode's placed on the VMO, the other's placed on the quad. The pulses are put into the muscle to cause a contraction as is seen here. Typically, I'll have the patient hold the contraction for 10 seconds, and while the pulses are on, have them push the knee down into the table. Not only does this help improve quad function, but also helps them gain their extension. To improve patellar mobility, we teach patients to do patellar glides at home. Here you see Maddie performing medial and lateral patellar glides, moving the kneecap from side to side. We also teach superior and inferior glides as is shown here. This is particularly important in Maddie's case as she had a patellar tendon graft and we don't want the donor site binding down to the underlying tissues. To improve knee motion, in the clinic we'll do both passive and active assisted range of motion. At home we get patients to do heel slides to improve flexion and quad sets to improve knee extension as is shown here. At the end of the first session, Maddie's knee motion was from 11 to 80 degrees and she was all smiles after surviving the initial session. Next week, we'll work on improving knee motion, start some basic strengthening, and progress the home program.